My guest this evening is Dr. Melody Glenn. Dr. Glenn is an addiction emergency physician and associate professor at the University of Arizona, whose newly published first book, Mother of Methadone, is a hybrid memoir from Beacon Press that weaves her own story with that of the history of methadone maintenance and its founder, the radical Dr. Marie Nyswander. Her work has been supported by the DeGroote Foundation, the Arizona Commission on the Arts, and an Elsur Artist Residency, and her publications have appeared in both medical and literary journals. She's also a board member of the Cochise Harm Reduction. Did I get it all right?
You did. Thank you.
I'm not quite sure where to begin. One thing that struck me when I read the book, and I don't know whether this is intentional on your part or just something that I noticed, it begins and ends more or less in a parking lot.
That's true. I hadn't really thought about that, but it certainly does.
Um, and it's sort of a good metaphor because a lot of what you talk about is the word I use is stagnant. How our opioid or addiction treatment system is stagnant, and you're talking about somebody who's did their main body of work 50 years ago, and what you've tried to accomplish in the last dozen years, I don't know, 10,
Yeah, around there.
and the sad fact that there is not a whole lot of change in between the round one and round two.
Yeah, and that's what really shook me about learning about Dr. Marie Nyswander. So she went to medical school in the 1940s, and I went to medical school in 2009 to 2013. And for both of us, we learned very little about addiction. We didn't learn that addiction was a medical condition that we were capable of treating, that we had very effective treatments. In fact, methadone and buprenorphine are some of the most effective medications we have for any chronic disease, having the rate of fatal overdose. But we didn't learn anything about it. And then when we were practicing, same thing. And I just couldn't believe it that I found a mentor and someone to look up to and someone whose story explained my own, even though it happened so long ago.
One of the thoughts I had was that actually the doctors are in some ways no better off than lay people in terms of the views, the stigma, the opinions that we have about addiction and drugs and people who use drugs.
You're absolutely right. And again, that shocked me too. I thought that if I just presented my colleagues with the data, with the numbers from scientific journals, I mean, that's our currency, right? We're taught that that's the currency of academic medicine, that we can convince people that science is completely objective. But I would show people the numbers and it still wouldn't change their minds. And that's when I realized that there was something deeper at play here. There's stigma. And doctors are just people too, and we have the same stigmas, unfortunately. And I think that stigma lives more in our hearts and less in our brains. And so I was hoping that telling the story might appeal to their empathetic nature and change their minds maybe more than the data would.
When did you say to yourself, okay, this has got to be a book. I've got to get this down. I've got to get this, because this is well, you described, or in the introduction, and that was something you wrote, you described her as, Dr. Nyswander, as radical. Would you use the word radical for yourself?
I don't think I would, but I think other people might.
Yeah.
It's hard to see yourself as radical. I feel like what I'm doing is all makes a lot of sense, seems very rational, seems very normal, but somebody else might call me radical for sure.
Well, I would use the word bold and pioneering.
Thank you.
Okay. Um, so what, my question is, when did you say, okay, I'm writing a book?
I remember the exact moment. I was trying to write something about my medical training and my experience becoming a doctor, but it was just sort of a rambling mess. I had about 80 pages of rambling mess, and I turned it into my thesis advisor because I was getting a master's of fine arts in creative writing after my medical residency and fellowship. And my thesis advisor very rightfully said, "This is a mess. This is not good. We need to focus here. You need some focus." And so she recommended that I try writing a collection of essays instead, because each theme that I'm trying to address could be its own essay. And I could focus in on it, narrow it down, give me some structure. So I thought that was a good suggestion. I started to do it. And the thing that interested me most at that time was Dr. Marie Nyswander. So I said, okay, let me try writing an essay about her. And I got about 15 pages in, and I realized, oh no, this is its own book. She deserves her own book. I can't squeeze in everything here in 15 minutes. There's way too many complexities and nuances, paradoxes in her life, links to the history of addiction treatment that's still very relevant today. And then I found a way to weave my own story in too. But it was when I was trying to write this essay about her that I realized she deserved her own book.
One of the things, and this came from your writing class, in your book, you talk about being in, I think it's while you were getting your master's, and the teacher writing on the board, um, what haunts us, what hunts us, what are we hunting? And then later on, you said the answer to that is our life's work. So,
Yes, that was Dr. Trung Tran. He's a poet in the Bay Area. And I love that line of his. And that
well,
was what was haunting me. It was haunting me. Why does methadone feel so carceral? Why does it have so much stigma around it? Why does the methadone clinic feel so unpleasant? When I went for my interview, so I interviewed to become a methadone physician, and there was a big fence surrounding the clinic. There was a Tucson police officer patrolling it. There was some people laying in the corner outside in the grass, and the police officer was going over to them. Inside, there's lots of bulletproof plexiglass separating the patients from the staff. There's rules tacked to the walls about mandatory urine drug screens. I mean, I can't imagine going into a doctor's office that feels like this. When I went to my dermatologist's office, it's the far opposite end of the spectrum, right? There's bubbly water in a fridge, there's nice magazines on the table, there's fancy couches, everyone's smiling and welcomes you in. Why does the methadone clinic feel so carceral? And so that started to haunt me.
as well it should.
Yeah. Yeah.
Um, Now, you were experiencing the system as I say the system, I'm talking about writ large, because I encountered it as a father of an addict who ultimately couldn't get the help he needed or in the way he needed it. Um, but as a physician, it seems as I read the book and as I read the book about both of you, what I see are all the roadblocks and the stumbling blocks and the signs that said no, wrong way, don't do this. And some of them are what approved or the medical opinion of the time, and some of it is just outright sexism.
And sometimes it's hard to tell the difference.
Well, yeah, I guess maybe one difference between you and Marie is that there were more women in medicine when you were going through medical school than when she did.
100%. There was way more. Yeah, half of my class was women. And for her, she was just one of a handful. Yet she still didn't believe that there was sexism in medicine, which I just couldn't understand. I couldn't understand how she had that opinion, because me going through training almost 100 years later, and I see sexism all the time, how did she not even see it? And, you know, she didn't want to become an addiction physician. She initially wanted to be an orthopedic surgeon, which even today has the least amount of women as any medical specialty. That's what she wanted to do. And she enlisted in the Navy during World War II, hoping she could be sent to a field hospital in China, where she pictured herself doing orthopedic surgery. And they told her, sorry, we don't have a uniform for women. And so they sent her to work at the narcotic farm, which was half prison, half treatment facility. But that's not what she wanted. And she still didn't think that there was sexism. How is that possible?
Well, also just the way she was treated as a doctor there, the quarters she was given to live in,
Yeah.
uh, the way she was treated throughout the year. But the rebel in her certainly. I mean, your account of her giving people morphine as a Christmas present.
Yeah. Yeah.
I didn't know. Um, I knew about the the hospital in Kentucky. I didn't know that it was one of two. I didn't realize there was also one in Fort Worth, Texas, that was established at the same time. Can you tell our audience a little bit about what these were and what they were supposed to be doing?
Yes. So they were founded in the 1930s. Once prohibition came underway and we started criminalizing drugs, suddenly there was a lot of people to imprison. And we didn't have a good place to put them. Initially, they were putting people who were arrested for possession in the general population in jails and prisons. And the wardens started to get frustrated because they were introducing drugs and getting other people onto drugs. So they decided, okay, we need to put them in their own prison, their own institution. And we also couldn't decide if addiction was a crime or if it was a medical condition. Just like today, we can't really decide with our policies. We have almost this schizophrenic approach to it. So the Bureau of Prisons and the U.S. Public Health Service jointly ran these narcotic farms where people could come in voluntarily and get treatment, or they would be arrested for drug charges and put in mandatorily, and they couldn't leave, and that was the case for them. And they're pretty impressive facilities. People believed that if we had good, clean food, if people were eating organic, if they were outside, if they were playing sports, they would be cured. And this is a lot like RFK Jr.'s wellness farms that he's proposing. This is basically what we did in the 1930s. And there was also a lot of behavioral health treatments. AA and NA had offices or chapters, I suppose you would call it, inside the narcotic farm. So people were getting good behavioral treatments. Yet the relapse rate was still 90% when people left. So it didn't work.
So
And they
that's
shut it down.
now. What's interesting to me is that the one in Kentucky, at least, had a room for about 1,000 people.
Yeah, the jazz. So jazz and heroin were very much intertwined during this time. They estimated about 40% of jazz musicians were addicted to heroin. So there was a ton of jazz musicians at the narcotic farm in Kentucky. And because they thought that good, clean hobbies were part of recovery, they had musical training rooms, they had instruments, they had a giant stage with velvet curtains and amphitheater seating that could fit over 1,000 people. And some of the biggest jazz musicians of the time would perform on the weekends there, and you'd fill up the seats with folks from Lexington, locals. Other musicians would sometimes pretend to be addicted to heroin just so they could come to the narcotic farm and study with the greats. So it was almost like a de facto artist residency. Kind of cool. And Marie Nyswander played music too, so she was a pianist, and she would play with lots of the patients.
So she was there for a year, right?
Yes.
So she leaves for a year, and already she's abandoned the idea, appears to have abandoned the idea of being an orthopedist,
Yes.
and moves on into addiction medicine. Well,
Yes.
she moves into psychiatry first.
Right. She wanted to be a psychiatrist, a psychoanalyst. She wanted to treat the wealthy ladies of Park Avenue, maybe the ones who were dealing with marital strife, bored housewives, that kind of thing. That's what she wanted to focus on. But because of her experience at Narco, she had a lot of addiction knowledge that none of her colleagues had. So when they had a patient with addiction, people were completely failing them. There was in one of the books about her, they were describing a patient who was withdrawing from barbiturates, and she had a seizure, and no one knew what to do except Marie Nyswander. And she raced in and she got the treatment, and she scolded the doctor and telling him how to treat this. You have to slowly withdraw someone off of barbiturates. You can't just stop it cold turkey. But people didn't know that at the time. They didn't even know that barbiturates were addictive back then. So she was getting these phone calls. She became the de facto expert. Everyone was calling her when they had someone with addiction because none of the other doctors had learned how to treat it. So they were calling her. She wanted to put an end to all this. Still, she wanted to be a psychoanalyst. She hadn't given up on that idea. So she wanted to write a paper explaining how to withdraw people off of barbiturates, thinking that if she wrote this paper, got it published, no one would ever have to ask for her help again. But instead, it led to more phone calls, more success, because this paper wasn't just published anywhere. It was the New England Journal of Medicine, which as a resident, that's a really big deal. And so she became the expert.
And continued
Yes.
more and more, continued treating people.
Yeah, she was the only, then for a time, she was one of the few doctors in New York City willing to treat people with addiction. So she just sort of fell into this need. And she has a good quote saying, well, if someone needs a glass of water, how can you not give them something to drink? So she saw where she was needed, she saw what she was good at, and she stepped into that role. And then
So,
later, she was really grateful for it.
so in terms of addiction medicine, there's a certain serendipity in the the course of her career.
Yes, there was. She felt in the end that it had saved her. And same with methadone. When she discovered methadone maintenance as a treatment for heroin addiction, she felt like it had saved her. And really, she was facing extreme burnout and fatigue at that time because so many of her patients were dying. And becoming the methadone doc saved her
Now,
just as much as it saved her patients.
you mentioned before, I'm going back a little bit. You mentioned before that you had about 15 pages or so um, about her that you'd written. And then there was not, am I correct? There was not a lot of material about her. You had to do a little extra hard hunting, I guess, to say. Although I think you're probably pretty happy that you came across David Courtwright, the
Oh my
historian.
gosh. He was a godsend. I couldn't have done this project without him. So I came across one of his articles. What initially I couldn't find much about Marie Nyswander. Everything that was written was back from the 60s and 70s, and lots of the authors had died. So there was no getting in touch with them. But then I found a short biography that David Courtwright had written in the 90s. And then I saw that David Courtwright is still a practicing historian and professor in Florida. And so I reached out to him and he wrote back and we had a great conversation and he sent me a box of all of his materials that he had collected from interviews with Marie's mom, with Vincent, with Marie herself, with Joyce Lowens, and all kinds of people. And it was just so wonderful to get that box in the mail. I couldn't have done this without him.
And these were taped interviews.
There were some taped interviews. There was notes that he had taken. There were letters that he had written and received.
Yeah, I stumbled across him reading on the back of your book. You have Carl Eric Fisher, Jessica Hoppe, and Maya Solovitz all have written blurbs on the back of your book. They've all been guests on this show,
You've got a
and
great show.
yeah, I make a habit when when I read books, yours included. I often I start with the index to see who's mentioned in the index, what's going on, what is the web, what are the connections,
Yes.
and I came across David Courtwright's book, and I've got one of them. I need to get another now, but I and then after while I was reading your book just recently, I said I wonder if there's anything on YouTube or anything, and in fact you can find one or two YouTube pieces. He's a very interesting guy.
Yes, he is. Yeah, and he linked me to drug czars. He linked me to Dr. Jerome Jaffe, Dr. Robert DuPont. He
Um,
really made this all possible. And he also, a letter that was in that box clued me into the fact that Dr. Nyswander never really received the credit she was due for methadone's maintenance's creation either, which I think speaks to the sexism as well. There were lots of people who thought that methadone maintenance was solely her husband's idea and that it couldn't possibly have been hers.
yeah, as I read the book, I mean, you you tell the story, you develop it thoroughly, deeply, pick a word about what she has done, and then suddenly there's this question about did she have anything to do with it and her husband, but her husband was actually in a different field. I mean, he was the caboose to her train, and
Yes, exactly. That's why it was so shocking to me. I was just like, what? How can so many people think this? That's absolutely right. He was a metabolic researcher. He had a lot of political capital that he brought to the table. He made this all possible. She couldn't have done it without him either. But she was the one with all the addiction experience.
when you tell your story, you talk about uh, being involved with a an online what was it buprenorphine online
Yeah, the telemedicine.
telemedicine. Thank you for helping the old man out. and that you ran into a snag because of silly rules, for want of a better word. That you were the doctor, you were the chief medical officer. Is that correct
Yes.
for this small group? And they were based in Michigan, and suddenly you get something in the mail about the time, of course, about the time you deliver your first child as well.
Yes.
You get something in the mail telling that you violated some rule about prescribing, which was something you knew nothing about, or
Right.
certainly wouldn't have done had you known. Um,
And they referred to the buprenorphine, this medical treatment, as prison heroin, which was just so telling to me and shocking. Another shock. I keep getting shocked with all the barriers that come with addiction medicine. You think I'd be used to it by now, but every time it just sort of slaps me in the face. But yeah, they were calling this life-saving treatment prison heroin. And I think that's the real reason they were coming after me. They were making it too accessible.
well, now, most of the time in the book, you talk about buprenorphine and you say buprenorphine. I saw once, and it was somebody else, it was a patient talking, I believe, talking to you, talking about Suboxone.
Yes,
Can you, for people that are listening, can you describe the difference, if there is
definitely. Yeah, buprenorphine is the main ingredient in Suboxone, and Suboxone is the trade name. Buprenorphine is the generic name, and so I'm just trying to stick to the generic names to get away from brand names. I'm not trying to promote any one brand over another. There's other brands of buprenorphine. Suboxone is probably the most well known, and lots of people on the streets call it subs, Suboxone, but buprenorphine is the active ingredient.
it the only ingredient?
There's also naloxone in it, which gets very confusing to folks. The idea, so naloxone is the opioid antagonist, right? If someone overdoses and you want to reverse it, you spritz some naloxone or Narcan up their nose and they wake up. Suboxone has buprenorphine and naloxone in it. Buprenorphine is what's the active ingredient. That's what keeps people from having cravings, keeps people out of withdrawal, keeps them from using. The naloxone is in there in case people take the Suboxone and try to inject it. The naloxone only becomes active in your body if it's in the bloodstream. If you put it under your tongue like you're supposed to, it doesn't do anything. But if people inject it, it could make them go into withdrawal and feel very sick. So it's a deterrent from injecting. But I don't know anyone who would want to inject this. I think it's something that was developed to make doctors feel better, but it's not a real problem that needed to be fixed.
Right. Um, my most recent guest, or actually a most recent guest, not the last show, but was a man named Dr. Arthur Robin Williams, who was the chief medical officer for something called Affiliate Healthcare, Affiliate Telemedicine. Have you heard of
Oh,
them?
yes, I have.
Um, so I guess my question is, are there more than one tele telemedicine outfit?
There are
And,
several.
and has anybody learned from your mishap?
I don't know. Probably. But yeah, there are several out there. And I think they're a great way for people to access care, especially if they're in a rural area and there's no doctors or NPs, PAs willing to prescribe buprenorphine close to them. Telemedicine is a great way to do it.
Well, I was surprised in the interview just learning. I mean, you can do the urine test. I figured I'm going, come on, it's telemedicine. You can't do everything. Well, turns out you can do a whole lot.
Yeah. Yeah, we would give patients the urine drug screens and they would be on work sites. We had a guy who was like working on a construction site and he went to the porta potty and he like left his phone on and we're like, we don't need to see. We believe you. But yeah, you can do a lot over telemedicine. And some states even have telephone lines for buprenorphine where you call just a regular telephone number, no video at all, and you can get prescriptions, which is really
Really.
great. Yeah, I think Rhode Island started doing that during the pandemic.
And I believe, if I remember correctly, Rhode Island also giving medication to people that are incarcerated, and cutting down on the deaths.
Yeah, the entire state's overdose rates went down once they started offering treatment in the prisons and jails. Pretty incredible.
Yeah. Well, one of the things in reading your book, and this takes me back to the narco farm, where if you had two of them, so that maybe you've got 2,000 patients, inmates, whatever you want to call them, because they were both at a
Right.
place,
It's really, yes.
and being experimented on, some of them as well.
Yeah, that's how they
Um,
got in trouble. They got in trouble ultimately for experimenting on the patients slash inmates. Like they had some LSD studies with the CIA. It's an interesting history.
yeah. Although it still is now a medical facility for people that are incarcerated but need medical attention. Is that correct?
I'm not sure. I thought it was just a regular prison at this point. I'm not entirely sure. But I do have a friend here who is a clinical psychologist who used to work there.
Really?
Yeah.
Well, my question was, there are a thousand people at that one. I'm assuming probably the same number at Fort Worth, close to it. But the numbers, as you go through the book, the numbers of people that are incarcerated continue to rise.
Yes.
Two things continue to rise. One is the number of people that are incarcerated, uh, and incarcerated for drug offenses, and then also the number of people that are dying from overdoses.
Yes.
I
I
mean,
don't think that's unrelated, right? Yeah, I
can you
think that's
just say that one more time? I missed it.
I think that's related, right?
Oh,
We
yeah, sure.
like we are continuing to see addiction as a criminal problem. And so we continue to see the solution as incarceration, which we know doesn't work. We've done this before. It didn't work then. It doesn't work now. When we really started to focus more on the war on drugs, the penal population ballooned. In 1970, we had only 300,000 people incarcerated. By 2010, it was more than 2 million, with drug convictions making up the majority of the increase. And it's estimated that about 2/3 of people who are incarcerated currently have addiction. Unfortunately, very few of them are actually getting treatment in these prisons and jails. Although more prisons and jails are offering treatment, it's spotty and it's really hard to get good data on what's available.
Well, it's also when we say they're getting treatment, um, are they getting medication? Are they getting
That's
is
why when I say treatment, I'm mainly mean medication. But yes, more and more jails and prisons are offering buprenorphine, but it's very limited as to who gets it. Some institutions are just doing it within 30 days of release, or just the people who are already on it. They're not initiating it. And so the risk of fatal overdose upon leaving is very, very high.
yes. There's a villain in all this piece, or at least I think so. Um, is it Harry Anslinger?
Yes, he's a good villain. He's an easy villain.
Can you tell us a little about him?
Yes. So he was in charge of the DEA's forerunner, the Bureau of Narcotics and Dangerous Drugs. And he held that position for several decades. He was notoriously racist. He hated black people. He hated jazz music. He hated cannabis because he linked cannabis with jazz and with black people. And he really started targeting. He used the war, he really started the war on drugs, and he used it as a way to target racialized populations and enact terror. He also really tried to stop anyone who disagreed with him. When physicians spoke up and said, hey, we have treatments for addiction, we have medical treatments available, he would try to ruin their careers. He would send agents to scare them, to harass them. He would ban books. One of the books that really influenced Dr. Marie Nyswander, The Opium Problem, was written by a husband and wife physician couple in the early 1900s, and it talked about our country's first maintenance clinics. We were actually giving out morphine and cocaine to people who were addicted. and not able to stay abstinent. Well, he tried to make sure that book was banned. He tried to get rid of it. So book banning has been a technique that people have been using for quite some time.
Um, no comment.
So, I truly tried to make this history feel alive. It's not just something relegated to the past that's irrelevant and dusty. We're doing all of it all over again.
Well, yeah, absolutely. What are the parallels? Give some examples and one of parallels between Marie's experience and yours. 50 years apart, and yet it's like the same signs are up on the road saying,
Exactly. Exactly. It's shocking to me. So, yeah, neither one of us learned much about addiction in medical school or residency. We initially thought, we initially hated when we had patients who had addiction because we felt frustrated, like we weren't able to do anything. And we had these cross narratives, right? I'd have patients who are coming in asking for help. I didn't think I had a way to help them. And I would see them as trying to manipulate me. Marie felt the same way. That was the hidden curriculum that we had both been taught during our medical training. And I see that with practitioners today. I see that with residents, with doctors, with EMTs, with paramedics. Until people realize that we have these very effective treatments, they get very frustrated because they see the same people coming in over and over again after overdoses, and they feel like they can't help. They feel like there's nothing they can do. It's a revolving door. They're getting this moral injury because they're unable to do anything. But we actually have very effective treatments. And once Marie and I learned that, we became obsessed with these things. Methadone sort of saved both of us. It saved her in her moment of burnout when she was thinking of giving up because so many of her patients were dying. And it really, addiction medicine saved me when I was feeling burned out as an emergency physician, treating the same people over and over again without really feeling like I was making a difference. And for both of us, it feels like we're almost alone coming up against this system, feeling like we're crazy, right? Everyone's trying to make us feel like we're crazy because we're saying, hey, it should be a lot easier to get the treatment than the poison. But there are so many barriers in place.
yeah. Well, one phrase that's in your book and two others that I've heard, um, treated and streeted, frequent flyers, and three hots and a cot.
Yeah, these are all ER terms. We've got a lot of lingo in the emergency department.
Yeah. Well, three hots and a cot I heard from my son when he was in inpatient for a period of time. Um, and that's it was interesting. The same hospital, they had a outpatient floor and an inpatient floor, and the philosophy about treatment and medication treatment was different. The bottom floor and the top floor didn't even in the same hospital weren't on the same page. Uh, and he was the one that's how I heard about three hots and a cot. I think there are probably some others out there too. We don't need to. We don't,
Yeah.
what would you, if you were creating a course on addiction now, or what would you do for medical students about addiction now? How?
I would want to have some anti stigma training. I'd want to talk about trauma informed care because it's estimated that about 2/3 of people with addiction had traumatic experiences when they were younger that causes them to be more prone to addiction. So we want to talk about that, how we can not repeat traumatic experiences for our patients, how we can make sure the hospital is not a controlling enforcement environment. Of course, I'd want to talk about buprenorphine and methadone. And beyond talking about it, I think it's so important for students to see firsthand how effective it is and how well it works. I love being with the residents the first time they give these medications because it really is a revelatory moment for them. Because nothing else we do in the ER works that effectively or that quickly. And you think of the ER as things are supposed to be fast, right? We're supposed to cure things quickly, but that doesn't actually happen most of the time. But with these medications, it does.
Now, do you have, aside from the medication in your ER, do you have any peer counselors or anybody available to work with?
I would love that. We just applied for a grant. I hope we get it so we can have peer recovery coaches in the emergency department, because starting the medication is one thing, but then making sure people get to continue that when they leave is another. So many of our patients have so many barriers to picking up their medication. They might be homeless. They probably don't have a car. They may not have enough money to go pick up the prescription. They don't have a phone, so it's hard to make their follow-up appointments. So it'd be really nice if we had a peer to help them navigate some of those barriers in the healthcare system. Or maybe they need a prior authorization. All these things that just get in the way. So it'd be great if we had peer counselors. Unfortunately, it's hard to convince hospital systems to fund an additional position if they don't see revenue coming in from it.
I'm I'm shocked. I I would have assumed that you had. I mean, I asked the question naively, thinking, well, of course you've got peer coaches and peer counselors and peer advocates or peer anythings, and apparently they're not appearing, so to speak.
They're not. And then it doesn't, they're not highly paid positions, so it seems like it's not that much of a burden for the hospital system to pay for. But when you've got people who are looking at the numbers and looking at whose lives matter.
Well, even within, speaking of pay, uh, pay for addiction doctors is lower. Am I correct? Lower on the scale than what some other doctors might get.
Yeah, but I feel like that's the least of the problems that we've got with reimbursement when it comes to addiction medicine. But yes, that's true also. And it just blows my mind how differently we treat addiction than we treat other medical conditions. Right? In my hospital and at the state level, we treat trauma patients, people with cardiac arrests, with heart attacks. We treat them like genuine emergencies. We have whole systems of care developed. We have cath labs that are available 24/7, trauma bays, operating rooms, trauma surgeons, lots of resources poured into this. When a paramedic or an EMT responds to someone who's having a heart attack, they race them off to the hospital, lights and sirens. When they respond to someone who's having an overdose, sometimes they give them Narcan, not because they actually need it, but just to wake them up enough so they can ask the patient, hey, can we just leave you here instead of bringing you to the hospital? And getting a refusal. They don't even see them as worthy of going to the hospital, which is just so different than how we treat people with a cardiac arrest or a heart attack, even though the mortality rates are about the same. Someone having a STEMI, which is the biggest kind of heart attack, the mortality rate is around 10% a year. And that's the same for someone who's overdosed that EMS responds to. It's the same acuity, but we don't treat it like that. Lots of hospitals don't even have one addiction physician at them, not even one.
Now, when you say lots of hospitals, are you talking across the country?
Yes.
I mean, I'm a spoiled New Yorker. Uh, Although I've read enough to know that the number of physicians that are board certified in addiction medicine is not very high,
It's not very high.
um, and there aren't that many people that are part of the American Society of Addiction Medicine.
No. And some states, like Wyoming, doesn't even have a methadone clinic, the entire state.
Wow. So what do you have to do? You have to move.
Or maybe one of these telemedicine companies can help.
Yeah. Can they help with methadone?
No,
Yeah, it would be buprenorphine. Do you
can't
have a
be.
preference? Do you have a preference between the two, or
I do. I if Well, first of all, I let my patient decide. In the end, it's what they want. But if they don't have a preference, I try to steer people towards buprenorphine because it's safer, it's harder to overdose on, it has less interactions with other medications, it doesn't affect the heart as much, it's less regulated, so people can pick it up at any pharmacy theoretically. They can theoretically get it from any doctor. So it's a little bit easier to access and it's a safer medication. So if people don't have a preference, I'll try to steer them towards bupe. It also works faster if someone's in withdrawal. Otherwise, But I think methadone is a great option, and for the people who it works well for, it works very well.
Um, of the people that come in, I would imagine a lot of your patients are already have at least some familiarity or some awareness about methadone and buprenorphine, and may have their own opinions, which may not always be based in fact.
Yeah, people do have experience. Lots of people have tried it from the street. There was a good paper out there that showed that most diverted buprenorphine, which means buprenorphine that people get off the streets instead of from a doctor, is used correctly. People are using it to treat withdrawal. And there's also evidence that the best way to reduce diverted buprenorphine is to make it more accessible. When it's too hard to get from a doctor, then you have people selling it on the streets. And so people have tried it before. People do have preferences. And there is stigma too. Lots of my patients hold stigma against these medications. I've had so many patients come in and they tell me, I don't want to be on this. I don't want to be on this long term. I want to get off in a couple of weeks. And the data shows that people should be on it for at least 2 years before they start to titrate off. Because it takes that long to sort of change people's habits and change their lives and get more stable, to get in a really stable place, because it is hard to come off of buprenorphine or methadone. They are both opioids. The withdrawal can be difficult. So you want to work with your medical team to come off very slowly and have relapse prevention plans and all of that. But so many people want to get off sooner than is recommended because they've heard so many negative things. People, they hear an NA that a drug is a drug and they shouldn't be on these medications. They hear sometimes at their churches that they shouldn't be on these medications from their family members. We don't treat other diseases the same way, right? If someone has diabetes, we don't tell them they need to get off of insulin. If someone has high blood pressure, we don't shame them for being on metoprolol or amlodipine. Why do we do that with buprenorphine and methadone? It's stigma.
Yeah.
And it's really hard to root out because it's on so many levels.
How many patients do you come across and do you encounter on a regular basis?
I probably see about 1,000 patients a year with addiction.
Really?
Yeah.
And then, of course, you're seeing a number of them more than once.
Yes. But not that many, because this number, the 1,000, that's the number I got from our consults in the hospital. So those are often new patients.
Wow. And how does it work in terms of? I just saw somebody scoot in and out there.
Yeah. My husband, we share our home office.
It's okay. I've had interviews where we've had dogs barking and kids screaming and all the rest of it. So
There's that famous British interview that was on national television where the kid scoots in and then the wife comes to try to get the kid out and then the other one runs in.
yes, yes.
Yeah. At least the kids are at school.
If somebody comes in, somebody's new to you. How often you can start them on, let's say, buprenorphine. So you start them on buprenorphine, and how many visits? How long does it take to get things settled and regularized, and how are you able to follow up, or are there patients where you just don't know?
Most of them I just don't know. We do have a clinic, but I refer lots of our patients in the hospital to other clinics in town. We have a lot of good treatment options in Tucson. Luckily, El Rio is our federally qualified health center, and they have a really robust addiction treatment program. And we have a methadone clinic, Kodak, that's open 24/7, which is unique. There's not that many of those in the country either. So patients can literally just walk straight over there from the hospital and get plugged in. So I refer lots of my patients out elsewhere. I don't know how many are actually getting treatment, though. There's one study out of an ER that showed without the warm handoff, without a peer navigator doing a warm handoff, 0% of their patients continued on treatment. I think our numbers are better than that, but they're probably not as great as I would like them to be.
Yeah. you have any population? Are there any population statistics in terms of who's getting? It comes down to, I presume, the diseases of despair that all the people that are unhoused, people that don't have work, people that are racial
Yeah.
minorities.
Yes.
Um,
And we've mainly been talking about opioid use disorder here, but we also treat people with alcohol use disorder. That's even more common than opioids. More people drink and have problems with alcohol than opioids, and more people die from that every year.
right.
But we don't have quite the magic bullet that we do for opioids.
And there's somehow, stop me if I'm wrong, but somehow there's less stigma associated with alcohol use.
Oh, 100%. I mean, so many work events have alcohol involved at them. There's happy hours everywhere. There's so much alcohol in our country. It's hard to get away from it.
And you can buy it in, when you buy it, you know what you're getting, you know what the content is, you don't need to worry about it being polluted with anything else.
That's right. We have a safe supply. Yes, and we tried prohibition with alcohol. It didn't work. So now we've accepted that there are harms and risks associated with it, and we just try to reduce them. We use harm reduction.
Well, okay, speaking of harm reduction, who are your who are your in terms of methadone, you wrote a book about it. You've got Marie Nyswander. Who are your heroes? Who inspires you in terms of harm reduction or anything else in terms of learning about addiction?
Yes, my harm reduction heroes are more local. There's Haley Coles, who founded Sonoran Prevention Works in Phoenix, and she really did lots of advocacy in the legislature to change policy in Arizona. Got some huge wins there. And Sonoran Prevention Works is one of the biggest nonprofits distributing naloxone in the country now. There's Lou Funk, who's the founder of Cochise Harm Reduction, where I volunteer on the board of directors. Lou Funk has really transformed harm reduction in a rural community, which is something pretty unique. Most of the national successes in harm reduction are in big urban areas where they have a lot of support and lots of like-minded folks. And Lou's doing this in one of the most rural counties in Arizona and has gotten national attention for it. So, and just has changed my mind time and time again about what harm reduction means. Now they're even including things like helping people with their pets when they have to be hospitalized, because lots of people don't want to stay in the hospital if they've got animals to take care of. So that's Cochise Harm Reduction's role has expanded time and time again to include things that our participants really need in a visionary way. Philip Feudy, who's in New Mexico, he and his friends developed one of the very first leave behind naloxone programs in the early 1990s. Again, in this rural community, no one really thought much about them. They were doing something very visionary and revolutionary. Christopher Thomas, he's mentioned in my book, he opened my eyes to lots of harm reduction practices too. And also gave me inspiration to keep going when times get tough, when it feels like there's barrier after barrier, but we got to keep doing it. Like that quote that you sent me. Christopher Thomas showed me that.
Oh, really?
Well, that attitude, that persistence, despite
Oh,
the
oh, oh,
obstacles.
okay. Yeah. I was saying, how did he get a hold of that? I
Well, it's a
wrote
very good quote.
that quote. um, are you? Uh, the answer, I guess, is yes, just based on the back of your book, but on the jacket cover. But are you part of a network of how are you connected to a network of addiction specialists and addiction researchers and addiction authors?
Yes. So the authors, we've just started to meet each other through events or through our books. I think that's how a book launch goes. You start to meet other people who are like minded, and it's been very fun in that way. by a part of the American Society of Addiction Medicine, or ASAM, which is a national organization that represents addiction medicine providers. And it's been a lot of fun and very fulfilling and provides the inspiration that I'm looking for. It reminds me that I'm not alone in this.
Now, I asked at the beginning, I talked about parking lots, and in your last chapter, you're in a parking lot and you're engaging in what I would call some risky behaviors. You start to help practice grassroots harm reduction. You're actually out distributing materials and stuff. You still do any of that? Can
Not
I
so
ask?
much. Yeah, you can ask. You can ask. Sometimes I do. I mean, I'm involved with organizations that do it, but like with Cochise Harm Reduction, I've gone out with them in the field a couple of times, but more I help on the with more administrative tasks now, being on their board of directors.
Um, I found, I know the word I was looking for before. I said, referred to you as Anne Marie as pioneers. Another word I came up with, I went to the thesaurus, I came up with mavericks.
That sounds really nice.
Um, and then there's a quote from Marie talking to David Courtwright, where she says, when you find yourself doing something nobody else does, it behooves you to ask, am I out of line? Have you had to ask yourself that question?
All the time. I always think I'm a little crazy. I always wonder if I'm the crazy one. But then I think about it some more. I mean, sometimes I am, maybe, but most of the time, I don't think that I am. I think that the rest of the world is being crazy by thinking that addiction doesn't matter, by thinking that people who use drugs don't matter. They're the crazy ones.
I couldn't agree more. Um, do you have anything else you'd like to add? Do you have a benediction for us or anything that we particularly need to know?
I don't think so. I think we covered a lot of really good ground.
Okay, well,
I guess I
I'm
could
Bill
tell
Williams. Go
I
ahead.
could remind them my book. So if you want to read more, I'd appreciate your support. My book is called Mother of Methadone. You can find it online wherever you order books, or you can support your local bookstore and ask them to order a copy for you.
I have a copy of my own. It is. I've read it twice, and it's well marked up.
Well, thank you.
I can show you. These are on my notes.
That's amazing. Thank you. Thank you for the careful read. I really appreciate that.
Yeah, no. Well, I need to learn.
We all
So
do.
I'm Bill Williams. Thank you so much for listening tonight. There's more to my interview with Dr. Melody Green. Melody Glenn. Hear our full conversation on the Kingfisher Project podcast at wjffradio.org. You can also find past interviews with great guests, authors, advocates, policymakers, physicians, and those in recovery, all up now at wjffradio.org. And be sure to join me right here next month for a new edition of the Kingfisher Project. Information against addiction, right here on the local edition, only on Radio Catskill.
I have to be a little older first before I can be gone for such extended times.
Yeah, yeah. We're waiting. I've just got to get somebody to look in the. Hang on, I
Okay.
can listen. I don't want to hold you up, but let me get.
Technical assistance.
I did not touch the board. I have nothing to do with the board. I did a whole interview one day, and they came in and they said it didn't record, and I had to call the doctor. This was a doctor who lost his son,
Oh, no.
and the interview was actually about his own ignorance about addiction and stuff. And we did the whole thing over again the very next day. He said, "Let's do it," but I don't touch the board, and I'll be right back. I got to get
Okay.
pro help.
looks like you are good. Let me just get pictures here.
Hang on, we got to get the Grandmaster, and then we can.
All right.
Thank you so much for doing this.
Thank you so much. It was such a pleasure.
I'm in the Catskills, out in the woods, and I read. I've reached a point where I just say, write the person, get an email, get in contact with them, and see if they're willing to do it.
Yes.
And the response is generally, well, people want to sell their book, but the response is generally so gracious and so
Yes.
overwhelming.
And I think authors are excited to get a chance to talk about their work. It's been such an isolating, solitary project for so long that this is finally the fun part, talking to people about it.
Well, I have. Can we keep talking?
Yeah, go.
Okay.
No, you want to keep recording?
I have an idea. I have a project I'm working on, which is taking a bunch of these interviews and doing an anthology of the interviews.
Oh, yeah. That'd be really cool.
So if you get an email sometime saying, guess what? I'd like to use our interview. I discovered that actually this stuff is the station's property or my property. It would just be taking transcribing interviews and putting them together.
Yeah.
Different points of view and different information.
That's a great idea. I mean, sort of what David Courtwright did with his oral histories book. Which is that's where the interview with Marie and her husband where they're published, and a bunch of other people from that time. There's a bunch of oral histories of heroin use in New York.
Oh, okay. All right. You're free?
Nope, 1 second.
Oh, you're not free.